session. Then there'll be a Q&A session for like 10 to 15 minutes. I'll ask the questions. I'll look at the chat box, ask the questions you can answer. And after that, we would be having a quiz and a survey. But if you have any other commitments, you can stay. Please feel free to stay for that. But if you have any commitments for quiz and survey, you don't have to be here.
Sure.
But we'd love if you were. Nice to meet you.
It's nice to meet you. My last name is Kalianos, is how it's pronounced.
Kaliana.
Yes.
Okay, perfect.
Kali like the
Thank
dog. Kalianos.
you.
Not spelled the same way.
You can never pronounce my last name.
I cannot, which is what.
Okay. All right. We'll go live and
Great.
we'll start the session. Thank you.
Thank you.
All right, a very warm welcome to everyone for another wonderful session of Academic Radiology Education Program. Just a very brief thing about how the program works and what we do. So I'm Dr. Janardana Ponatapura, JPM, one of the cardiothoracic radiologists in Wake Forest University School of Medicine. So AREP is a nonprofit initiative online program which is aimed at providing a high-quality radiology education to radiology professionals globally. So this is led by the Department of Radiology at Wake Forest University School of Medicine in Winston-Salem and collaborated with many major radiology institutes in Asia and Middle East. So the program's goal is to share Western experience with the radiology colleagues across the globe, enhancing radiology knowledge and practice worldwide. So we have Dr. Kimberly Kalyan. I'm so sorry if I misspelled the last name. She is an associate professor in cardiac and pulmonary imaging in Department of Radiology and Biomedical Imaging at University of California, San Francisco. So she's received her medical degree at Harvard Medical School in Boston, Massachusetts, and completed 1 year of internship at Mount Auburn Hospital in Cambridge, Massachusetts. She completed a 4-year diagnostic radiology residency, followed by cardiac and pulmonary imaging fellowship at UCSF. She has a great passion for teaching and was selected as the radiology resident liaison for medical student teaching during her training. She also completed a dedicated year of advanced research training under the NIH Research Training in Biomedical Imaging grant. Her current projects include collaborative research efforts with faculty from cardiology, transplant hepatology, and rheumatology, focusing on the use of cardiac MRI for assessment of myocardial disease, including the strain imaging and pulmonary hypertension and T2 analysis of myocardial iron overload. She's interested in quality improvement research, including radiation dose reduction and resident faculty agreement in interpretation of coronary computed CT angiography. She's published numerous publications, over 50 peer-reviewed publications. And please welcome Dr. Kimberly, and she would be talking about pulmonary manifestations of connective tissue disorders and vasculitis. Over to you, Dr. Kimberly.
Thank you so much for that very nice introduction, and it's my pleasure to be here with you all today. I'm Kim Kalianos from UCSF, and as that very nice introduction described, I'm going to be focusing on pulmonary manifestations of connective tissue disease for the lecture this morning. This is a big topic, but I think we're going to hit on some of the major highlights, and then I welcome any questions or feedback at the end of the talk. So I will go ahead and share my screen and begin my presentation. All right, let's jump right in. I have no relevant disclosures. So I think let's just start off with the diagnosis of connective tissue disease-related pulmonary pathology. How does one know that the presentation of the patient is actually related to an underlying connective tissue disease? How do folks get these connective tissue disease diagnoses in the first place? It's important to know that this is part of a multidisciplinary diagnosis. We as radiologists play a part, but we also have clinical workup, serological analysis done by our colleagues in rheumatology, and then, yes, pulmonary findings as a primary manifestation, and that's my particular area of expertise as a cardiothoracic imager. So let's take each of these in turn. In terms of the clinical diagnosis of connective tissue disease, there's a combination of clinical and serologic criteria that are used in classifying a patient into a particular connective tissue disease diagnosis. This usually doesn't include pathology, but it can include biopsies of extrathoracic tissues like salivary gland or muscle tissue. And it's important to know that the presence of lung disease or pulmonary pathology is not actually part of the diagnostic criteria for any of these diseases, with the exception of scleroderma, which actually has a very high frequency of interstitial lung disease, and we'll talk about that quite a bit. This is a summary of some of the physical signs and symptoms that are used in the diagnosis of specific connective tissue diseases according to the American College of Rheumatology. And you can see that there's dermatologic findings, musculoskeletal, ocular, renal, neurologic, a whole spectrum of symptoms that are used to come to this diagnosis. Now, I said that lung disease is not part of the diagnostic criteria with the exception of scleroderma, but do patients actually present to care with a new diagnosis of connective tissue disease coming in with pulmonary symptoms? And the answer is yes. ILD is actually a common connective tissue disease presenting symptom. And what's interesting to see is from a few studies that have been done in the last few decades, a not significant portion of patients coming in with a presumed idiopathic interstitial lung disease, so just coming into a pulmonary physician's office with pulmonary symptoms, ultimately receive a diagnosis of a connective tissue disease, either at presentation or in the follow-up period. So what that means for us is that folks that don't carry any history of connective tissue disease coming with pulmonary findings, these folks may be having their initial diagnosis of this disorder based around the current presentation. So many of these folks are initially suspected of having IPF, but ultimately are diagnosed with a connective tissue disease. What are some of these serologic testing results that can yield a connective tissue disease diagnosis? The multi-society practice guidelines actually talk about this specifically, and I just have a quote here from those guidelines. This is from the 2018 document. And the authors recommend that patients with a newly detected interstitial lung disease of apparently unknown cause who are suspected of having idiopathic pulmonary fibrosis should undergo routine serologic testing to exclude connective tissue disease as a potential underlying cause. So again, even if your patient is coming in with a presumed idiopathic presentation of diffuse lung disease, serologic evaluation is recommended. Of course, it's important to also understand that just because someone has a positive autoantibody, that does not necessarily mean that they have a connective tissue disease. And so that gets into what are these what are these autoantibodies that we're testing for? The first that is sent for many folks is ANA, or anti-nuclear antibody. And it's important to understand that not only is the positivity of these antibodies important, but the titer is very helpful in correctly interpreting the results. So you can see on the little schematic on the slide here that very low titers may reflect a false positive. So about a 30% false positive rate in folks who have a titer that's positive at a 1 to 40 dilution. But when you take that all the way down to a 1 to 320 dilution, the false positive rate drops substantially. So it is important to be thoughtful and think critically about the autoantibody results. Now, in addition to positivity and titer, there are also staining patterns of anti-nuclear antibody. I've illustrated, taken images on the side of the slide there of a few of these different patterns. Anti-centromeric pattern of staining is actually one of the diagnostic criteria for scleroderma. Is the ANA sensitive for diagnosis of connective tissue disease? In some situations, yes. Scleroderma and lupus has a very nice performance. However, there are other connective tissue diseases where ANA, which is the general kind of screening lab, is not very helpful and has a likelihood ratio of 1 for a particular diagnosis, whether or not the patient has a positive ANA. A nice example of that is anti-synthetase syndrome, which is a myositis-associated pulmonary disease. Those folks tend often not to have a positive ANA. So just because your ANA is negative does not mean you don't have a connective tissue disease, there are many other autoantibodies or serologic tests we can send. So I'll just go through each of these in turn. Rheumatoid factor, right? That's going to be indicative of rheumatoid arthritis if positive and has a high sensitivity and specificity. Anti-CCP actually has even better diagnostic performance with a very high specificity, and you can see two very nice examples of the same patient with RA-associated interstitial lung disease progressing over time. And we'll talk about the particular parenchymal findings in just a bit that make us suspicious about a connective tissue disease-related interstitial lung disease. All right, what about myositis? I brought that up a little bit ago. These are patients who have autoantibodies against the aminoacetyl tRNA synthetase enzymes. There are a variety of these antibodies, and the more common are JO1, PL7, PL12. These are usually exclusive with one another, meaning you'll have only one positive antibody and not a whole positive panel. These are positive in about half of folks with myositis. And if you happen to have one of these autoantibodies, your likelihood of ILD is increased. The majority of folks who have autoantibody positive antisynthetase syndrome go on to develop interstitial lung disease. So the subset of patients with inflammatory myopathies who have these particular autoantibodies, they're at very high risk of significant interstitial lung disease. And then this table just summarizes some additional useful or high-yield autoantibodies and the particular connective tissue disease with which they are most closely associated. Depending on the setting in which you're practicing, your patients may or may not have access to these tests. And these are send-out tests, right, that may need to be sent to an external lab depending on your institution. And so knowing to recommend these or being able to have an informed discussion with pulmonary medicine about what type of testing might be useful to the patient is something that we can do just by increasing our familiarity with these tests. All right, so now let's get into our domain as radiologists. We talked about physical exam findings and the laboratory testing that might be done for your patient. What about the CT results? How can we help in this diagnosis? There are a few patterns of diffuse lung disease or interstitial lung disease that are relatively commonly seen in patients with connective tissue disease, and those include nonspecific interstitial pneumonia, organizing pneumonia, an overlap of NSIP and OP findings concurrently in the same patient, and lymphoid or lymphocytic interstitial pneumonia. So let's talk about what each of these patterns look like. Here's a very nice example of a 37-year-old patient with mixed connective tissue disease and NSIP. NSIP is the most common interstitial lung disease in patients with connective tissue disease, and it's characterized by symmetric reticulation, traction bronchiectasis, and relative paucity of honeycombing. That has those that description there has very good performance for NSIP versus UIP. And one of the particular CT features we see in folks with NSIP is ground glass opacity. Right? So what does this represent? That's a question that comes up quite frequently. Ground glass opacity can represent inflammation, but it can also represent very fine fibrosis below the resolution of the CT, for example. And so we need to look for other evidence of fibrosis to help us determine whether ground glass opacity in a particular patient is an acute inflammatory response or actually reflects fine fibrosis. And in terms of, how do we do as radiologists in differentiating this, it's quite challenging. One particular study actually did biopsy of these folks and saw inflammation in about 65% and fibrosis in 35%. But fortunately, the majority of patients with fibrosis on histology had traction bronchiectasis present on the CT scan in the region of the ground glass opacity. So that's a sign that I use. If I see ground glass and there's traction bronchiectasis going through that region, I feel more confident this corresponds to fine fibrosis as opposed to something inflammatory. And the test of time is also helpful as well. Does this improve or respond to anti-inflammatory medications or immunosuppressive medications, or does it progress to worsening fibrosis? So the retrospectoscope can also help us feel more confident about what the initial manifestations of the patient's disease represented. Here's an example of a patient with fibrotic nonspecific interstitial pneumonia. You see that reticular opacity, symmetric, and then the very notable traction bronchiectasis that you see in the lower lungs on this patient. And as I mentioned, a variable imaging appearance from inflammation to fibrosis is possible with this disease. And there's a very strong connection of nonspecific interstitial pneumonia pattern with connective tissue disease. But of course, medications, inhalational exposures, and other etiologies can also underlie the occurrence of nonspecific interstitial pneumonia. More examples, right? We are imagers. We learn by pattern recognition. So 2 more examples of patients with connective tissue disease-related interstitial lung disease and a nonspecific interstitial pneumonia pattern. One feature that's quite common and helpful in the diagnosis of of NSIP is subpleural sparing. This isn't a sensitive finding, but is actually very specific for the diagnosis of nonspecific interstitial pneumonia. So if you see subpleural sparing, your specificity is increased for the diagnosis of NSIP. Moving on to the next pattern, organizing pneumonia. Organizing pneumonia in the setting of connective tissue disease looks similar or nearly identical to organizing pneumonia from other etiologies. We have symmetrical peripheral or peribronchovascular regions of consolidation, ground glass opacity. These can be rounded or in arcs in their morphology. Very nice example of OP there. And the atoll or reverse halo sign is another feature that can help us in the diagnosis of organizing pneumonia. Here's an example of the atoll or reverse halo sign. You see a peripheral rim of consolidation with central clearing or central ground glass opacity, and then a satellite photo of an island with a similar configuration, rim of beach or reef, and then water in the center. So while this isn't seen in the majority of patients with organizing pneumonia, when it is seen, it's a very specific sign. Other signs you can see with organizing pneumonia include the perilobular sign. This is the presence of poorly defined arcades or polygons of consolidation, thicker than just interlobular septal thickening and often surrounding more than one secondary pulmonary lobule. These tend to be located in the periphery of the lung as well and abutting the pleural surface. And when you combine features of nonspecific interstitial pneumonia and organizing pneumonia into the same patient, you get this NSIP-OP overlap syndrome. Here are 2 patients with myositis demonstrating symmetric peripheral fibrosis. You can see subpleural sparing in the patient on the top, but we also have a superimposed component of consolidation or peribronchovascular consolidation. So features of both NSIP and OP. And the consolidation component on CT corresponds to organizing pneumonia at histology. If you see this pattern, you should be quite suspicious for antisynthetase syndrome or a myositis-associated interstitial lung disease. The next pattern I want to talk about is lymphocytic interstitial pneumonia or lymphoid interstitial pneumonia. This looks different than the other pathologies we were talking about. We have patients in this situation who have interstitial infiltration of the lung parenchyma by lymphocytes and plasma cells. And we have some combination of ground glass opacities, small ground glass nodules, and cysts. So a very unique and a different appearance than the other patterns we were just talking about. Lymphoid interstitial pneumonia occurs on a spectrum with follicular bronchiolitis, which is also this infiltrative process with excuse me, immunologic cells. And you can see 2 patients here with connective tissue disease, a patient with Sjogren's with a combination of ground glass and cysts, and a patient with biopsy-proven follicular bronchiolitis with these small ground glass nodules. So the combination of ground glass opacity and cysts will help us to make this diagnosis accurately in a patient with connective tissue disease. What about usual interstitial pneumonia pattern of pulmonary fibrosis? Can we see this pattern in patients with connective tissue disease? Well, we know that in male patients and older adults, the most likely cause of UIP pattern is idiopathic pulmonary fibrosis. However, if we have a younger patient with this pattern or a patient who's female, connective tissue disease or other causes of UIP pattern, for example, familial fibrosis or medication exposures, raise up on our differential. And we're going to focus on connective tissue disease for the talk today. Are there CT clues that can help us know that a UIP pattern in a patient is more likely associated with connective tissue disease as opposed to idiopathic? And the answer to that is yes. There's a paper from AJR in 2018 that actually described a few different morphologic features of the patient's fibrosis, including the anterior upper lobe sign, which is involvement of the anterior aspect of the bilateral upper lobes, four corner sign, anterior and posterior lung, the straight edge sign, which is a sharp demarcation between lung involved by fibrosis and normal lung, which you can see on that coronal image on the bottom of the slide, and then something called the exuberant honeycombing sign, which is where you have very robust, bubbly or cystic appearing honeycombing in the regions of fibrosis. The specificities of each of these signs alone for the diagnosis of connective tissue disease-related UIP pattern is quite high, 87%. And if a patient happens to have 2 out of 3 or more of these signs, you also have a very high sensitivity and likelihood ratio for CTD UIP. So these are important features to recognize, especially again, if a patient is coming into you without any known diagnosis or with a presumed idiopathic lung disease, you may be able to suggest a diagnosis of connective tissue disease, again, particularly if the patient is younger in terms of their demographics. So something that I've thought a bit about is, why do we have this exuberant or bubbly honeycombing sign? I think this just reflects the evolution of fibrosis, or the maturation of fibrosis in patients with connective tissue disease related interstitial lung disease. Here's a patient with a classic non-specific interstitial pneumonia pattern in the setting of CTD. They have both temporal and spatial homogeneity in terms of their fibrosis, bilateral, symmetric, reticular opacity. There's some mild traction bronchiolectasis and subpleural sparing as well. Very classic NSIP pattern. Well, what happens as the fibrosis matures or worsens in a patient like this over time? You can imagine that if you develop honeycombing, it will be in a similar distribution, right? Symmetric in time and space. And that's what gives you, or can give you, that exuberant honeycombing and that anterior upper lobe sign. So does this actually happen? Does NSIP evolve radiographically into a UIP pattern? The answer is yes. And so there's a study of the long-term follow-up of patients with non-specific interstitial pneumonia. And the CT pattern in about a third of these patients, a quarter to a third, progressed from imaging findings suggestive of NSIP pattern to imaging findings more consistent with UIP pattern over a relatively short follow-up period, 3 years. And here's just a patient from our own practice, a young patient with mixed connective tissue disease. You saw their slide earlier in my talk with a very nice example of fibrotic, non-specific interstitial pneumonia. And then you can see the worsening or progression of fibrosis occurring over a few years. And by the time we reach about 15 years later, this patient has progressed now into a UIP pattern with very exuberant or bubbly honeycombing. This is connective tissue disease related usual interstitial pneumonia in a patient with mixed connective tissue disease. So it's a CTD-ILD with this morphology. Other patterns of lung disease that we can see in patients with connective tissue disease include diffuse alveolar damage. This is going to be seen, excuse me, more commonly in the setting of exacerbation of interstitial lung disease. And what you will have is new ground glass opacity or new consolidation superimposed upon your existing findings of fibrosis. In particular, patients with anti-synthetase syndrome and who have a subset of autoantibodies called anti-MDA5 autoantibodies are very prone to develop a rapidly progressive interstitial lung disease characterized by diffuse alveolar damage. It's important to know that exacerbation of interstitial lung disease, as well as MDA5 anti-synthetase syndrome itself, both have a very poor prognosis and a high mortality rate. Here is a young patient coming in with rapidly progressive hypoxic respiratory failure, ultimately leading to lung transplant over a 3 months time. You may have seen a similar situation in someone coming in with idiopathic DAD, but this is actually a proven case of anti-MDA5 myositis anti-synthetase syndrome. And you can see at the time of their transplant pneumonectomy, they have DAD with NSIP patterns consistent with CTD-ILD. All right, so we've talked about lung parenchymal findings in patients with connective tissue disease related pulmonary involvement. What about extrapulmonary findings or other findings that we can see in the chest that don't necessarily fall under the interstitial lung disease bucket? We call this multi-compartment disease. And the classic things that I look for when I'm looking at a chest CT of someone with connective tissue disease include airways disease, serositis, pleural and pericardial effusions, as well as evidence of pulmonary hypertension, which is particularly relevant in patients with scleroderma. Of course, you can have other manifestations of the patient's connective tissue disease. For example, in someone with scleroderma, they have esophageal dysmotility. Someone with myositis can have calcification of the muscles. So you can have pathology associated with a particular disease as well. But I just want to hit on these three. We're talking about mosaic attenuation. So that means there are different regions of lung density. Some lung is more opaque and some lung is more lucent. And so we need to figure out why a patient has different lung density. And what I ask myself is the opaque lung abnormal or is the lucent lung abnormal? If the opaque lung is abnormal, what we're talking about is ground glass or consolidation. And of course, there's a differential for those, and we can go down that differential. What if we think the lucent lung is abnormal? That's also known as mosaic perfusion, the lucent lung being abnormal. And the reason the term mosaic perfusion is used is because most of the density of lung is due to blood. So what are the causes of decreased blood flow to the lung parenchyma? Vascular disease, like chronic PE, for example, or small airways disease with corresponding air trapping, and then VQ match, right? You have poor ventilation of portions of the lung, and because of appropriate physiologic response, your body down regulates flow to those portions of the lung. The presence of air trapping can be helpful in confirming that you have small airways disease as the cause of your abnormal lung lucency. And I really only bring this up as a major finding when a patient has marked mosaic attenuation, which means that it's present bilaterally and in 3 or more lobes, not just a single lobule, for example, of lucency, or a single lobule of air trapping is very common in the basilar lung. All right, so this slide just illustrates the different patterns of mosaic perfusion due to small airways disease versus vascular disease. You can see on the left side of the slide that there are larger regions of differential lung density in a patient with chronic thromboembolic disease. The lucent lung occupies a large portion of the lung periphery, with the more opaque lung located more centrally, and that has to do with previous peripheral or distal embolic phenomena. That's in contrast to a patient with small airways disease. You can see lobular regions of differential lung density, so corresponding to 1 or 2 secondary pulmonary lobules. This is an inspiratory scan. If you go ahead and do expiratory imaging, the difference in density between the normal and abnormal lung becomes even more marked. Those areas of air trapping remain lucent, which is pathological, and the rest of the lung actually increases in density as the patient breathes out and has expected atelectasis in the expiratory phase. Here's just an example of a dynamic expiratory scan. You can obtain expiratory imaging static at a particular time point of the whole chest, or in a dynamic manner such as this. And it's important to know that these can be done at a very low dose technique. You're certainly not going to be necessarily having to repeatedly scan the patient in inspiration and in expiration, so we can be thoughtful about the radiation dose. As I mentioned, static or dynamic. And you can see here, I mean, just looking at this particular example, my accuracy for the diagnosis of air trapping or airways disease is going to be greatly improved by the presence of the expiratory phase here. And that's been backed up in the literature as well. And then finally, I want to talk about pulmonary hypertension. The World Health Organization, or WHO, has several groups of pulmonary hypertension. And the one that we're talking about in folks with interstitial lung disease or connective tissue disease related interstitial lung disease is group 3, pulmonary hypertension, PH due to lung disease and or hypoxia, and there are a variety of different lung diseases or causes of hypoxia that fall into this WHO group 3. Important to see that some of these are ones that we as radiologists are very helpful in the diagnosis of, for example, severe COPD or interstitial lung disease, but there are others that don't necessarily have imaging findings, for example, sleep apnea or high altitude. So not every cause of group 3 pH will be apparent on a patient's imaging. This is an area of particular interest for me. Pulmonary hypertension can be quite challenging. So what does it mean when we say a patient has pulmonary hypertension? It means they have an elevated pulmonary artery pressure, and there are cutoffs at rest and during exercise that our colleagues in cardiology can evaluate. In terms of the particular size of the pulmonary artery, that's variable in the literature, and a variety of different size cutoffs have been proposed. But depending on the age of your patient and the size of the patient, you may have better or worse diagnostic performance. So actually, one internal reference point that's quite helpful is to compare the diameter of the pulmonary artery to the diameter of the aorta. A pulmonary artery to aorta ratio of greater than 1 is a better predictor for the presence of pulmonary hypertension versus pulmonary arterial diameter alone. And you can see the positive predictive value is quite high there, PPV of up to 95%. So in my practice, when we're going through a large number of cases quickly, being able to see and compare the PA diameter to the aorta diameter can give you a clue right away that you're dealing with pulmonary hypertension. And then, of course, you can make measurements and report. And it's important to know, and I think I mentioned this a few slides back, that the vast majority, 75% or greater, of folks with connective tissue disease related to interstitial lung disease and pulmonary hypertension are those associated with scleroderma or a diagnosis of systemic sclerosis. So if you happen to see a patient with an early ILD who has pulmonary hypertension, scleroderma should come to mind as a potential underlying diagnosis, and then we can look for physical exam findings, serologies to make that diagnosis. I just said here the pH size on its own is not necessarily as accurate. There's our sensitivity and specificity ranges. There's our PA diameter. And then I just want to make a caveat that a normal PA diameter doesn't necessarily exclude the presence of pulmonary hypertension. So if your colleague from cardiology comes and says this patient has PH, but their CT PA diameter is normal, that's okay. And it's also important to understand that PA size can progressively increase in patients with pulmonary hypertension independent of the pulmonary artery pressure when measured at catheterization. So if you see someone with known pH and their pulmonary artery continues to dilate, it doesn't necessarily mean that their pH is poorly controlled or that they need a change in their medication regimen. Once we have the diagnosis, then it's really in the hands of cardiology to manage. All right, and as I just said, we do see pulmonary hypertension in patients with interstitial lung disease. Not surprisingly, the incidence of PH increases in a patient who has more severe interstitial lung disease. Folks with end-stage idiopathic pulmonary fibrosis, for example, greater than 60% of those patients have some degree of pulmonary hypertension. And it's interesting, there's actually a poor correlation between the severity of pulmonary hypertension and the degree of fibrosis or degree of decline. So you can have only mild to moderate pulmonary hypertension in someone with very severe lung disease or in a pre-transplant fibrosis. So it's not necessarily a one-to-one relationship between the severity of the pH and the severity of the patient's interstitial lung disease, which is interesting. So this table just summarizes some of the common and less common manifestations of connective tissue disease that we see in the chest. You can see the connective tissue disease on the top of the slide, and then some of the patterns of pulmonary fibrosis that we see in these particular patients, and then some of the additional findings or non-fibrosis findings, airways disease, for example, constrictive bronchiolitis, effusions, DAD, hemorrhage, pulmonary edema. All right, so this is just a quick overview if you're looking at a patient with a suspected CTD-ILD, some of the associations. And then I want to take a moment to talk about interstitial pneumonia with autoimmune features, which is a relatively new and evolving concept. This is called IPAF, which is interstitial lung disease with an autoimmune flavor, if you will, but someone who does not meet the diagnostic criteria for a specific interstitial, excuse me, specific connective tissue disease yet. If you look through the literature, other terms may be used, and depending on the country in which you're practicing, other terms may be more commonly used. For example, undifferentiated connective tissue disease, lung-dominant connective tissue disease, and autoimmune featured diffuse lung disease are examples of some of the additional terms that you may see in the literature. But the idea here is that the patient has a lung disease and probably has a connective tissue disease, but we can't quite figure out what connective tissue disease they have. And so to get this diagnosis of IPAF, you need to fulfill criteria in 2 of 3 domains, and those domains are clinical, serologic, and morphological. You can see the excerpt from the European Respiratory Society, American Thoracic Society research statement on the side of the slide here. Clinical domain, that's some of those features that we talked about in the diagnosis of connective tissue disease. Serologic domain, we talked about many of these autoantibodies. Where do we as radiologists come in? It's the morphologic domain. And the suggestive radiologic patterns by HRCT are those that we talked about in this talk as well. NSIP, OP, NSIP with OP overlap, and LIP. You can also have one of those entities on a surgical lung biopsy done by our colleagues in pathology, or interpreted by our colleagues in pathology, and then multi-compartment involvement. So involvement of the pleura, the pericardium, the airways, or pulmonary vasculopathy, all of which we've touched on in this talk. So just zeroing in on the morphologic domain, the suggestive patterns for a diagnosis of IPAF include NSIP, OP, NSIP with OP overlap, and LIP. Although it's important to understand that studies have identified a number of IPAF patients with HRCT patterns other than those in that morphologic domain. For example, patients with UIP pattern who probably have a connective tissue disease, patients with HP pattern who probably have a connective tissue disease. So it doesn't mean that you cannot be given a diagnosis of IPAF with one of those patterns. You just have to meet criteria in the other 2 categories, or fulfill the criteria in the other 2 categories, or add on multi-compartmental disease. So here's just an example of how you might do that. You have qualify under the morphologic domain by having some type of lung finding that's not one of the big 4, plus unexplained pleural or pericardial effusion, unexplained intrinsic airway disease, constrictive bronchiolitis or follicular bronchiolitis, unexplained pulmonary vasculopathy like pulmonary hypertension. And here's a patient who has diffuse alveolar hemorrhage, pleural and pericardial effusions, and a positive anti-dsDNA antibody. This whole constellation is really suggesting that their lung disease is due to a connective tissue disease, and they would be able to receive a diagnosis of IPAF, even if they didn't meet diagnostic criteria for any one connective tissue disease at this time point. All right, what about the prognosis and treatment of patients with connective tissue disease-related interstitial lung disease? We know that overall, CTD-ILD has a better prognosis compared to folks with idiopathic pulmonary fibrosis. This probably has to do with a variety of factors. Our patients tend to be younger with CTD-ILD. However, progressive pulmonary fibrosis in a patient with connective tissue disease behaves more like IPF in terms of the rapidity of PFT decline and the overall mortality in these folks. And you can see here, this actually was a very young patient with anti-Jo1 positive antisynthetase syndrome with progressive pulmonary fibrosis over 7-year follow-up, going from findings looking more like NSIP-OP overlap into findings looking more like UIP pattern of fibrosis. So you certainly can develop a progressive pulmonary fibrosis phenotype in the setting of CTD-ILD. So what about this progressive pulmonary fibrosis? The multi-society guidelines or multi-society clinical practice guidelines put out an update around the diagnosis of idiopathic pulmonary fibrosis in 2022 and specifically talked about what progressive pulmonary fibrosis is. So PPF, or progressive pulmonary fibrosis, is patients with a known or unknown interstitial lung disease other than IPF, who have worsening fibrosis over time. And that can be evidenced by worsening respiratory symptoms, worsening pulmonary function testing, and there's some cutoffs there that our colleagues in pulmonary medicine can use, as well as radiological progression of fibrosis. And they go all the way and actually describe what particular imaging findings we're looking for that are consistent with radiological progression. And this is what you would expect to see: increasing traction bronchiectasis, worsening reticulation, increasing honeycombing, increasing volume loss. So not surprising features suggesting progressive pulmonary fibrosis. So going back to the focus of our talk, patients with interstitial lung disease associated with an autoimmune disorder or a connective tissue disease, do these patients develop worsening or progressive pulmonary fibrosis over time? The answer is yes. And those guidelines actually they summarize a variety of papers looking at the frequency of a progressive fibrotic phenotype in patients with a variety of different connective tissue diseases. And the shaded portion of these boxes illustrates the frequency with which patients develop progressive fibrotic lung disease. And you can see that in some connective tissue diseases, rheumatoid arthritis, scleroderma, or systemic sclerosis, and mixed connective tissue disease all have a reasonable percentage of patients who go on to develop progressive pulmonary fibrosis. And that's in contrast to other connective tissue diseases, lupus, for example, where it would be very uncommon for a patient to develop progressive fibrosis. Why does this matter? It matters when you're talking about the treatment for the patient's lung disease. So what is the role of immunosuppression in the treatment of patients with pulmonary disease in the setting of connective tissue disease? Immunosuppression is the mainstay of treatment for patients with connective tissue disease-related ILD, and that can include steroids or steroid-sparing agents, of which there are a variety. And these are particularly useful because not only do they address the inflammatory component of a patient's lung disease, but they also address the extrapulmonary symptoms that we haven't talked too much about, right? Musculoskeletal symptoms, neurological symptoms, renal symptoms. Immunosuppression is going to address all of those, so not just for the lungs. But we don't want to give immunosuppression, of course, to every patient who has a lung disease. We know from the literature that immunosuppression can actually be harmful in some patients with lung disease, particularly patients with idiopathic pulmonary fibrosis. And there's a study that was done a decade back or so that actually had to be halted due to an increased risk of death in idiopathic pulmonary fibrosis patients treated with immunosuppressive regimen. So we do need to make sure that a patient actually has a connective tissue disease before we start giving them immunosuppression. What about antifibrotics? Antifibrotic therapies have come on the scene in the last number of years. And these are really exciting therapies in that they have been shown to slow the decline of lung function in patients with IPF. Of course, they don't cease the decline, and IPF still has a very poor prognosis overall, but we can offer these therapies to some patients. And perhaps that will continue to develop in the future in terms of the effectiveness of these therapies. So what about giving antifibrotics to patients with connective tissue disease-related interstitial lung disease? Is this helpful? And the answer is yes. We have slower PFT decline in patients with progressive pulmonary fibrosis that is not IPF, including patients with connective tissue disease-related ILD. And particularly nintedanib has been shown to be useful for this indication. Of course, we must be thoughtful. These medications are extremely expensive and also have a side effect profile that we must take into account. So I'm certainly not advocating that we give to all patients, but these are useful and do slow PFT decline in patients with fibrotic CTD-ILD. Just taking a closer look at nintedanib, the Multi-Society Clinical Practice Guideline update in 2022 does suggest this medication for the treatment of progressive pulmonary fibrosis in patients who have failed standard management for a fibrotic interstitial lung disease other than IPF, for example, CTD-related ILD with a fibrotic phenotype. And it's interesting to know, I took a look here at the committee vote in terms of how strongly the committee members felt toward the use of nintedanib. And you can see that there is a strong recommendation and a conditional recommendation in a large percentage of the group, about a third strong and two-thirds conditional. So in terms of the level of confidence of our multi-society guideline members, that's where we are today. This may continue to, I'm sure it will continue to evolve over time. All right, what about lung transplant? Transplant is ultimately the outcome for some patients with connective tissue disease-related interstitial lung disease, depending on the practice setting in which you are practicing or the setting in which they are receiving care. Age is a major factor in transplant candidacy. Fortunately, CTD-ILD patients tend to be younger than those coming in with idiopathic lung disease, so they may be a greater percentage of your pulmonary transplant pool, as opposed to older patients who have IPF who may be above the age limit for transplant at your institution. There is variable data on transplant short and long-term survival in folks with connective tissue disease. Some papers say better than idiopathic lung disease, idiopathic fibrosis. Some papers say worse than idiopathic fibrosis. And I think what it's important to think about here is complications from extrapulmonary manifestations of the patient's connective tissue disease really play a big role in how these patients do in the short and long term. For example, a patient with scleroderma with very severe esophageal dysmotility and ongoing aspiration, if that patient undergoes a lung transplant, you're still going to have major challenges with aspiration. And so that may affect their long-term prognosis. All right, I think we've come up at time. So just to review, we talked about the diagnosis of connective tissue disease-related interstitial lung disease, the clinical diagnosis of connective tissue disease, serological data, as well as lung and extrapulmonary findings in patients with connective tissue disease. We talked about IPAF, this subset of folks with an early CTD who also are coming in with lung findings. And then finally, we talked about prognosis and treatment for these patients. I'm sure there is much that will be developing in coming years, so stay tuned. This is an active area of research around the world. Thank you so much for your attention.
Thank you so much, Dr. Kimberly. I mean, this is very illustrative, very educative. It's such a complex and dynamic thing. In my opinion, I think interstitial lung disease is one of the most complex topics in the whole, like the medicine. It's so dynamic and so complex. It changes every year. And thank you so much for making so understandable, especially ILD with connective tissue disorders is always like a mystery.
It's definitely
Yeah,
a challenging topic, but I think we can be really helpful for our patients in this area. And if our increased comfort only helps our patients.
correct. And especially with the newer clinical trials on the antifibrotics, I guess. I mean, historically, we just had two antifibrotics like the nintedanib and pirfenidone. I guess there may be around like 10 or 12 clinical trials going on antifibrotics, which may be coming soon in the coming years. And this would be like huge, I guess.
Yes, absolutely. And depending on the country in which you're practicing, you may have these on the scene earlier. So I really look forward to seeing the data.
Yeah, thank you. So let's move on to Q&A session. We have a couple of questions on the Q&A. The first question is, in a patient with suspected pulmonary manifestation, if CTD for whom chest X-ray normal, should you still proceed with HRCT?
I think it depends on the presenting symptoms of the patient. So this is something I'd actually be really interested to see what a pulmonologist would say as well. Why are we suspecting that they have CTD-ILD? If they have no pulmonary symptoms, they have normal PFTs, a normal 6-minute walk test, normal oxygenation, I think it's fine for patients not to have a CT if they really don't have any pulmonary symptoms. However, if you start having abnormalities, dyspnea, hypoxia, abnormal 6-minute walk, abnormal pulmonary function testing, then it's very appropriate to go for HRCT, and that's how they practice at my institution. There are some patients who you have a very high suspicion that they will ultimately develop interstitial lung disease, particularly patients with scleroderma, who sometimes do get screening CT, even in the absence of significant pulmonary symptoms. But I really think that's going to be based around how your pulmonary medicine colleagues are practicing and thinking about resource utilization, the payment of your patient for these services, and that's clearly going to really vary by institution. So I would say symptoms, PFTs first. If normal, might be all right to forego CT unless you have a very high suspicion of ILD, for example, scleroderma patient.
Yeah, thank you. So second question, thank you for your presentation. I have two questions. The first is, when do you require lung biopsy to diagnose ILD as well as CTD ILD? And the second question, I cannot imagine the brief process of lung biopsy in this scenario because there are no mass or nodules in the lung. Do pneumothorax or alveolar hemorrhage happen after most of the procedures?
Yeah, I think that's very insightful. So lung biopsy for the diagnosis of interstitial lung disease, we're usually talking about a surgical lung biopsy, not a percutaneous or a bronchoscopic biopsy. And that's just because from speaking with our pulmonary pathologists, they want larger pieces of the lung tissue to look at the architecture and come to a diagnosis. So yes, you're sending a patient for a very morbid procedure for a surgical lung biopsy. Usually they take at our institution, they take multiple samples, 3 different samples of the lung parenchyma. And so yes, you can have pneumothorax, you can have bronchopleural fistula, you can have hemorrhage. We actually have, unfortunately, seen exacerbation of interstitial lung disease in the setting of a surgical lung biopsy. So we know the prognosis of that is poor. All that to say is we're quite thoughtful about when we proceed with a lung biopsy. And this is part of the multidisciplinary diagnosis. So depending again on the practice where you're working, if you have the ability to have a multidisciplinary conference for patients with diffuse lung disease, including radiology, pathology, pulmonary, rheumatology, all together in a room, you can come to a diagnosis for many patients without having to necessarily go for surgery based on the laboratory, the clinical findings, and the lung parenchymal findings. If you have classic morphology of a particular lung disease, you may be able to forego a biopsy and spare the patient from those complications. Although I will say there are situations where a biopsy is really helpful. Indeterminate CT pattern or very mild findings, you're not really sure what they represent because the pathology, the histopathology, can help guide whether or not a patient needs immunosuppression, needs antifibrotics. So it can affect the treatment of the patient. So that's kind of it's not a definitive answer, but it's a real world answer. So we have multidisciplinary diagnosis. We try to come to a diagnosis from the data that we have, but a surgical lung biopsy is sometimes useful and will affect the management of the patient.
Thank you. Question 3, how to differentiate fibrotic NSIP and UIP?
Yes, great question. Sometimes we cannot. Other times we can. So I use the American Thoracic Society criteria for the diagnosis of the UIP pattern in the setting of IPF, and I apply that in the setting of connective tissue disease as well. So we know that definite UIP pattern is patients with basilar and peripheral fibrosis, reticulation traction bronchiectasis, and the presence of honeycombing. So if you're meeting all of those criteria, we know from those guidelines in the setting of IPF that the positive predictive value of radiologic UIP for histopathologic UIP performs very well, greater than 90% PPV. So that's what I'm looking for. Basilar and peripheral predominant fibrosis, reticulation traction with the presence of honeycombing. If you do not meet all those criteria, you're not meeting radiologic UIP. And then you might fall into this probable UIP category, which is sometimes a dilemma, right? That's peripheral basilar fibrosis, reticulation traction without honeycombing. And we know that some of those patients, if you do a biopsy, will have UIP pattern, and some of them will have fibrotic NSIP or other patterns. That might be a place, again, where a biopsy is helpful. So I use the ATS guidelines to try to make a diagnosis of definite UIP. If I can't, and they're falling into that probable UIP category, that can sometimes be challenging. You can look for other features suggesting NSIP, however. For example, if you have subpleural sparing, that really increases your confidence of a fibrotic NSIP. I also think the homogeneity versus heterogeneity of the lung fibrosis is helpful. We know that UIP pattern is temporally and spatially heterogeneous, meaning some areas of fibrosis are worse, some are less severe, there's normal lung intervening. Looks very heterogeneous, whereas NSAP tends to be more temporally and spatially homogeneous. So if things are very symmetric, all at the same level of fibrosis, that might make me favor NSIP, or would make me favor NSIP in some cases over UIP. But there are situations where both remain in the differential, and again, that might be appropriate for a biopsy.
Thank you so much. Just a follow-up thing on that. I had a question. So if NSIP, how often NSIP involves the upper lobe? Is involvement of upper lobe a differential features between NSIP and UIP?
In the setting of connective tissue disease, either of those can involve the upper lobes. So I personally don't use that as a distinguishing feature.
Okay.
We know, right, that CTD UIP even involves the upper lobes. The upper lobes tend to be involved in these patients. So
Right.
I don't
Right.
find that for myself a reliable distinguishing feature.
Okay.
I would
Thank you.
say that even if you're not sure whether the patient has CTD UIP or CTD fibrotic NSIP, we don't need to throw up our hands. Those are going to behave very similarly in terms of the prognosis of the patient. Those are both going to be potentially a progressive fibrotic interstitial lung disease. And so when we're looking at the outcome of these patients, we know that these are going to probably behave in a similar way. Probably would be useful to talk about antifibrotics for these patients. So even if you're not 100% sure of the pattern of the patient's lung involvement, if you can at least say, I think this is a progressive fibrotic phenotype, that is helpful for our colleagues in pulmonary medicine to talk about whether antifibrotics are appropriate for the patient.
Thank you. Thank you. Another question. Thank you for your excellent lecture and explanation. In your practice, do you always do inspiration, expirator, supine, prone, full protocol for all ILD cases, or do you have selection criteria for full protocol or callback on selective patients?
That is an excellent question. Yes, we have a selective protocol with callback for certain patients. And this has evolved at my institution over a number of years. We used to do a full protocol for all patients, supine, inspiratory, prone inspiratory, and then expiratory. We actually do a dynamic expiratory right now, but you could do a static expiratory. And what we found was, one, that's a longer appointment, takes up more time on the scanner. Two, more radiation to the patient because you're scanning them multiple times. And three, in many cases, in particular, the additional sequences were not helpful or were not needed. The diagnosis was very apparent just from the inspiratory images alone. And so you've obtained this extra imaging and it's not changing your interpretation of the study. So as a result of that, we actually now do a limited protocol, supine and inspiratory thin slice study. And then we do dynamic expiratory images at 3 levels in the chest for all ILD patients. We do not do prone as a standard. And then if you do have a patient with this mild peripheral fibrosis and you're really not sure if it's ILD or atelectasis, those folks we end up calling back to do a prone. I think that's a good use of resources at our institution. And I think especially if you're having folks come back for follow-up, again, you don't necessarily need to be doing all of these phases or all of these every single time. But it's going to depend on who's protocoling your studies. Are you protocoling them? Are they being protocoled by a trainee or a technologist? So really how much you're involved with the protocoling allows us to do these selected protocols.
Thank you. Thank you. I had one question, quick question. So what is the difference between IPAF and CTD-ILD? Like when do you call something as IPAF and when do you call something as CTD-ILD?
It's the difference is whether or not the patient actually meets criteria for a specific connective tissue disease.
Okay.
So the rheumatologist is deciding, or the pulmonologist, this patient has RA. If they have RA, a clinical diagnosis RA, and they have fibrosis, that's CTD-ILD. If they go to rheumatology and rheumatology says, I'm not sure, they don't really have a connective tissue disease. Yes, they have this antibody that's positive. Yes, they have, telangiectasias, but I can't make a clinical diagnosis of a connective tissue disease, but we're suspicious, those folks fall under IPAF.
Okay. Okay. Thank you. Thank you. All right. Thank you so much. I think that should be the end of Q&A session. We greatly appreciate you, Dr. Caliano, for making time and supporting this education program. That was very educational and an amazing lecture. Thank you so much.
It was a pleasure to be with you all, and I wish you all have a wonderful day or night, depending on where you are. Thank you so much.
Thank you. All right, so we would be moving towards our Q&A session, and I would pass it over to Dr. Turpanen, Nat, for the Q&A session. Nat, you there? Dr. Nat? Dr. Nat, you're on mute. Dr. Nat, we cannot hear you. I can see your slides now. I think Dr. Turpanen must be having some technical issues. I guess this is the question on the screen, I guess. Sorry, she was trying to call me, but I guess the question must be which patient is not in the group out of these 4 different patients on the images. So which is not in the group? So yeah, sorry for that. Nat had some technical difficulties. She's over the phone and she's going to ask the question now. Nat, you there?
Okay.
Yeah.
Okay, I'm here. I'm here. All right. I'm sorry for the technical issues here. So I have these 4 patients, and which patient is not in the group? Patient A, B, C, or D. I will give you 3 minutes to pick this right answer, and I will have the question at the end. So you have 3 minutes. We will start now. All right. I have your cell phone ready to scan the QR code. Okay, I'm going to time it now. 3 minutes.
Nat, do you by any chance be able to make that a full screen, please? Your PowerPoint presentation, can you make that a full screen?
seconds.
We have 1 minute, 30 seconds.
Yes, I'm sorry for this. I cannot make it bigger. Let me try this.
We have 30 more seconds.
All right, so I am sorry for the difficulty here. I do not know what's going on with the Zoom today. So all these 4 patients, can I speak, JP?
Yeah, please go ahead. You're on the speaker.
All these 4 patients does not have a surgical diagnosis. We did not do biopsy. Some most of them are like new patient and don't have any follow-up study. We are talking about the imaging features on a CT. Okay. For the first the answer is B. Okay, so for the first case, you can see that it's trying to be honeycomb all over here in the right lung base, a little bit on the left lung base. Is honeycombing appearance. For the second case here is traction bronchiectasis all the way here, especially in the right lung base, a little bit on the left here. It's like Hasbro glassy. This one has an SIP looking to it. This one, the patient does not have a lot of respiratory symptoms. Patient C, you can see like there is a little glass opacity, a little bit of traction bronchiectasis, kind of subpleural sparing here. So our assumption, because there's no clinical diagnosis yet at the time, so our assumption is this patient has an early NSIP, like a subpleural a scar plus a traction bronchiectasis and subpleural sparing here. Okay, for the patient that we have here, B, the prominent features is you see lobuli are trapping everywhere here, right here, especially in the right lung base. One, we see that is a very dominant finding. So this patient has HP. So it's chronic hypersensitivity, fibrotic hypersensitivity pneumonitis. So the patient who does not belong to the group is this guy, number B here, patient B, because our A, C, and D are related to vasculitis and connective tissue disease and UIP pattern. So we will look at your answer, and then we will pick the lucky person to get our gift this month. Last month is what Dr. Chaudhary from India. He got the right answer and got selected. So this month we will inform you next webinar who get the prize. I'm done, JP.
Thank you. And everyone, please make sure you evaluate this session. This is the QR code. Please use the QR code to evaluate the session. And also, just a reminder that the next topic would be on 2nd of June, and that would be on updates on renal cyst imaging. So we would be starting our abdominal imaging lectures, and would have like 4 lectures following this. So and the speaker would be Dr. Sadhana Verma. Like she's one of the pioneers of PI-RADS and she would be talking about updates on renal cyst imaging. That's on June 2nd, 2024. Again, a gentle reminder to use this QR code to evaluate. If you want the certificate, please complete the evaluation using the QR code. Well, thank you so much. Thank you, everyone, for staying back and attending such a wonderful session by Dr. Kimberly. Thank you so much. See you all in next 2 weeks.